Now, I'd like to introduce our current board president, Rod Gear. Rod, if you'd like to turn on your camera and take it away, Rod.
Okay, well, thank you very much, Steve. I don't need to introduce myself since Steve did. I'm a member of our board of directors, and I want to spend just a little bit of time talking about this 30-year-old organization that you are supporting today by your attendance. In fact, based on us two, which is sort of an umbrella organization for similar prostate cancer support groups in the country, we are one of the longest continuously operated such groups in the country, and that's something to be proud of. Additionally, and importantly, we are very proud of what we do. Our mission statement is simple and short, but pretty much captures what we try to do for you. Here it is, and it hasn't changed markedly since the very earliest days. We exist to provide men and their families in New Mexico with the most current information about prostate cancer, its detection and treatment, and to provide emotional support following diagnosis, during treatment, and beyond. The manner in which we started is worth going over because it kind of provides a better understanding of how we arrived at today. Back in 1986, there was a fellow in Albuquerque named Ray Shipp, and he received a diagnosis of prostate cancer that year. He underwent brachytherapy because that was one of the more common treatments in those days. And for the next 4 years, he thought he had no further worries. PSA screening began becoming much more common during that period of time. And when it became available to Ray, he quickly got a PSA test. It showed a very high PSA. Another procedure showed that the cancer had metastasized. So Ray started hormone treatment. But Ray realized his lack of knowledge, so he joined support sessions held by some national groups. That led him to becoming a trained facilitator here in Albuquerque for people seeking help. And that led him to hold his first prostate cancer support session, sort of informally and unofficially our first meeting, way back then in his kitchen table. All of this made Ray realize that men going through prostate cancer, and importantly, also members of their families, need to become educated and to have a ready support system. Well, the next date is October of 1991. That's when we became an official group. In those early days, many of the important services, protocols, and group values that exist today were established. For instance, no dues would be collected. We don't want to make anyone feel that they've got to meet some test to become a member. Also about that time, twice monthly meetings began at a local senior center, and they actually continue to this day. But we also believe we're nearing the day when these gatherings are going to become a more modern format, a hybrid format, with an in-person audience and an audience joining on computers, cell phones, at home, or wherever you may be. We hope that this will expand our regular reach throughout the state, because after all, we are called a statewide organization, and it behooves us to make every effort to really demonstrate that dedication to reaching throughout the state. But you don't need to be in Albuquerque or New Mexico to join in these gatherings. Last year's annual conference was held virtually, like the one this year today, and we had attendees from several states. Hopefully that's the case today. And maybe there's even somebody from some foreign country today. Okay, going back to 1993, we opened our first office. There was a logical reason. We wanted to create a library, to have a place to conduct the ability for people to check out books, but also, very importantly, to conduct one-on-one confidential sessions with prostate cancer patients. That, of course, is a core service and one that we know is much appreciated. We've still got our library in the office today, and we also now have videos, and hopefully you'll come by one of these days just to look around or to chat. We will be happy to see you. Here are a number of other important tidbits about our history. In 1994, we gained 501c3 status. That means your financial contributions, which we appreciate so very much, are tax deductible. Also that year, we developed a buddy system. It was developed so that the newly diagnosed person could consult with someone who had or was in a similar situation. In fact, that's sort of a key slogan that we've developed over time. We have been there. Our quarterly newsletters began publication in '95. If you've never looked at a publication, they're all dating back to 2007 on our website. So you can just go there. They're easy to find. There's a link that says newsletter. A few are still published. We used to publish a lot more, but if you're one of those folks who would like to hold paper, just let us know by sending a note to the office or calling us to see about getting your mailing, getting a hard copy sent to you. In 1997, the State Department of Health began providing financial support and remains our primary funder. It's a performance-based contractor deal, if you would, where we must demonstrate that we have done what we have promised to do in order to get those funds. In closing, it's important to thank all of you for staying with us throughout the past almost 2 years and for being here today. We so very much appreciate your presence, your suggestions and contributions, no matter whether they come by way of donating your time as a volunteer. And we are always looking for volunteers. That's something else you can volunteer to do when you come in to look at the library. And we also appreciate your dollars, which we see as a decision that you've made to invest in us being the best possible cancer support organization in the state or even regionally. Thank you very much. And now back to you, Steve.
Thank you, Rod. Now, well, let's go ahead and get right into the program. Our first presenter is Thomas Schroeder. He's an associate professor and radiation oncologist at the University of New Mexico Cancer Center. He currently serves as the medical director of radiation oncology, as chief of the radiation oncology section. He is a New Mexico native. He grew up in Santa Fe and has a bachelor's degree in physics from the Colorado College in Colorado Springs and a master's degree in aerospace engineering from Stanford University. He attended medical school here at UNM at the medical school and completed a radiation oncology residency at the Baylor College of Medicine in Houston, Texas. He also completed a fellowship in prostate radioactive seed implantation at the Seattle Prostate Institute, sponsored by the American Brachytherapy Society. Tom, if you would turn on your camera and your microphone, the floor is yours.
So Lou asked me to do a talk on genetic testing in prostate cancer. As many of you are aware, there's a lot of different genetic tests out there used for various purposes in prostate cancer. And I think quite a bit of it can be confusing. So I'm here to try and fix some of that. All right, so let's see if I can get my, okay, here we go. So here's a quick outline. We're gonna go over some terminology and some basic background. And then I'm gonna sort of review the types of testing, which is kind of, I've decided to break that down into more of the purpose of the testing. Then we're gonna review some of those tests. I'll try to stay away from the specifics of any test. I'll just kind of show you where we are with that and give you a scope of kind of how we're using those tests and what those tests can do to help with prostate cancer diagnosis and treatment. Then I'll show you just one clinical trial. There's more than one out there. There's actually quite a few out there. We have one that's open here at the University of New Mexico, and I'll review that. And then if possible, I'll try to answer some questions. I don't know if I'm going to be available at 11 o'clock to answer questions, but if there's questions after this, I'm sure the guys from the Prostate Cancer Support Association of New Mexico will email them to me, and I'll be happy to try and answer them. Okay, first off, let me give you a big warning. This is a big developing field. You know, the ability to assess genes, to look at genes, and to use that information to develop treatments or to better assess cancer is an ongoing and perpetually increasing thing. And this is changing by the minute. I am by no means an expert in this field, and it's quite difficult. But I think many oncologists, myself among them, think that this is probably going to change how oncology works for all types of cancer. Right now, we exist in a world where our current cancer classification is based on the cell of the origin of the cancer. In other words, if one of the cells inside your lung becomes cancerous, we call it lung cancer. Same thing for breast cancer, prostate cancer, etc. And right now, genetic testing basically augments that care. But I think in the future, and this is a big question mark, we're probably going to start classifying cancer based on what we see in the genetics of that cancer. You know, what types of mutations are we seeing? Are we seeing BRCA mutations, CHEK2 mutations, ALK mutations, et cetera, et cetera? And a lot of that is because we have treatments that are targeted specifically at those mutations. And those are the things that appear to be developing more and more as we move forward. I think it's going to be a little bit more complicated than that, but I think this is what we're going to see more and more. Okay, moving on. Here's some basic background. I got a cell over here on the left-hand side of the screen, and I'm just going to give some basic background for what DNA is and what a gene is. So DNA, deoxyribonucleic acid, is this complex molecule that you see down here at the bottom of the screen. And this molecule basically contains information on how to make proteins, enzymes, and those proteins and enzymes end up creating the structure of the cell, the function of the cell, and facilitate the cell's ability to live and function in the way that we need. Then you pile all those cells on top of each other with all those different functions, and you've got a form of life. These can be very complex forms of life, like humans. Genes are basically the sections of those DNA that compose a protein or an enzyme that is part of many of those processes of cellular function. The problem is this gets really complex fast because all of these things start to interact, and their different interactions is what kind of makes the process of life and function. So even though we may identify a gene, we may not know exactly how it functions and all the different things that it can impact. But this is sort of the root of kind of everything, and it's extremely powerful. And because of that, it's used to try and help us to figure out more about cancer and how we can treat cancer, detect cancer, and see if you're at risk of cancer, or assess how aggressive your cancer is. And that's the source of all of this genetic testing. Before we get too far in there, I think it's important that we differentiate between two different types of testing that occurs. Somatic testing is when we do the genetic tests on the cancer cells themselves. So this is where we're going to take a portion of your biopsy and we're going to look for mutations in it. This can tell us much more about the cancer And it can tell us, hey, is this cancer potentially susceptible to treatments that are directed specifically at those genes? Okay. Germline testing is where we're testing your normal cells. And this can potentially tell us about your risk of developing cancer and possibly the types of cancers that you may develop. It can also influence treatment recommendation because these germline cells are the cells that become cancerous. So their genes are preserved to a certain degree in your cancer cells. And so that may help us to determine treatments for your cancer. Genetic testing is done both on somatic cells and germline cells. All right. I have divided up the types of testing into sort of 3 different scenarios. Tests that are done to enhance screening. So this is when you haven't been diagnosed with cancer, but you kind of have an elevated PSA, or we think you may have an increased risk of cancer by some other test. And we say, okay, what can we do to see whether or not we should do a biopsy? So your PSA is 4.5 and you're 65 years old and it's been slowly rising. Do you really have to go and get a biopsy, or is there something we can do to see whether or not that biopsy is more or less important? The next is tests to enhance staging. So in this case, when I say staging, what I'm saying is, hey, what's your risk of cancer? Do we have to treat you more aggressively because we have understood that your cancer is more aggressive? Or can we perhaps treat you less aggressively or not at all because of things that we understand about your cancer? And there are multiple tests out there to look at that so that we can modify your treatment in order to minimize side effects and maximize outcomes. This is sometimes referred to more and more commonly as precision medicine or precision cancer care. That's where we're trying to precisely treat you, as opposed to in the past where we may have given you a treatment that may not have been precisely appropriate for you, but it was the best we could come up on based on what we know about sort of your stage or your risk. And then the last section I'm going to go to is testing to enhance treatment. And this is where we're testing to see, hey, are you susceptible to a specific drug or agent so that's going to work with you, or is that agent not going to work with you? And we're going to determine that based on a test. One thing that I should mention is all of these things enhance it, but these things are not perfect. So in other words, if you've got something that says, oops, sorry, let me go back up. If you've got something that says, hey, we really should do a biopsy on you because it really looks like, you may have an increased risk of cancer, so we're going to do the biopsy. That doesn't really mean the biopsy is going to be positive. It's quite possible that you could end up having a negative biopsy. And the same thing is true with the staging. We could have something that says, hey, your staging says that this is not very aggressive cancer, but then your cancer turns out to be aggressive. So these things aren't perfect, but they do help us to be more tailored in our treatment and biopsy choices. Okay, next page. So on the screen here, what I got is sort of the cancer progression, if you will, for patients with prostate cancer. Over here, I put PSA screening. I guess it could have been more generic and said just screening, but for the most part, the PSA is still dominating, the dominant tool in screening for prostate cancer. So we do some PSA screening, and if that looks like, hey, you might have a risk of having prostate cancer, then we go and we do the prostate biopsy. And then after the biopsy with your PSA and a digital rectal exam, we make some choices about, hey, should we do definitive treatment or should we go down here to active surveillance? And then while you're on active surveillance, we might go back to the prostate biopsy, or we might go to definitive treatment, depending upon what's happening during the active surveillance. And then after we've treated you definitively, you know, oops, sometimes the cancer comes back, or maybe we found you had metastatic disease at the get-go. And so, you know, we go over here and we do recurrent treatments. And this kind of represents sort of the path that prostate cancer patients go. So the first thing I'm going to talk about are tests that we do prior to even screening. Okay. And really right now, the only thing out there is some germline genetic testing. And this is where we're looking to see, hey, what is your risk of prostate cancer? Do you have an increased risk? And right now, for the most part, this is really just looking at some familial genetic syndromes that are out there, things like BRCA and others. The NCCN actually has some guidelines for that. They have a lot of talk about, hey, should we do this or should we not? And really what we're going to do to figure that out is we're going to ask about your family history, your personal history. Have you had prior cancers? What was the age of diagnosis of the cancer in those blood relatives? And then that can help us tailor as to whether or not you need to have this test or not. We don't recommend this test for people who, these types of tests for people who are just walking around and don't have a familial history of a lot of cancers. Those patients we usually just do PSA screenings on, and sometimes people don't even recommend PSA screening. That's kind of a whole nother discussion, but that's what's out there. Basically, germline testing is recommended in patients if they are diagnosed with metastatic prostate cancer, if they have first, second, or third degree relatives with breast cancer at an early age, colorectal cancer at an early age, male breast cancer, ovarian cancer, pancreatic cancer. And if you have more of those, and they have this whole set for when we should look. If you have somebody in your family who's undergone genetic testing and they are found to have mutations like BRCA1, ATM, the MLHs, the MSHs, all of those, then that can indicate, hey, you may have one of these syndromes like Lynch syndrome or another syndrome, and we should test to see if you have that because we may want to enhance your screening even if you don't have cancer. And this is for patients who have prostate cancer because that may affect how aggressive the prostate cancer is or your risk of developing other cancers. And then in patients with sometimes we can look and say, hey, if your cancer looks different, like if you don't have the standard prostate cancer, but instead you have a ductal cancer, which is rare, but I have seen 3 or 4 times, then we may want to test you to see if you've got, BRCA mutations because they're more common in patients that have ductal mutations, and there may be treatments available for those. And if you have 2 types of cancer, like you developed a colon cancer and you got pancreatic cancer, then we might want to test you there to see, hey, do you have a Lynch syndrome or do you have another type of cancer? Another type of mutation that it's going to put you at higher risk for cancer. This also is an area that is changing rapidly. And so you should be on the lookout for those changes because these guidelines are changing pretty quickly. Okay. Next, testing to enhance screening. Again, we got our standard sort of prostate cancer timeline. And if you look here, the next place we're going to check is right here. So we've done some PSA screening and we're saying, hey, do we want to do a prostate biopsy? Well, it turns out there's a bunch of tests to do that. I'm going to show you more on the other page. We can also use these tests here to decide, hey, you're on active surveillance. Should we do another biopsy? And some of these tests are advertised to be used in that section. And sometimes these tests can also be used to say, hey, should we put somebody on active surveillance or not? Now, before we get too far into it, I will tell you that none of these tests have been definitively proven. And I think I got another slide where I'm going to reiterate that point. These tests have not been definitively proven. In other words, we haven't taken a group of patients and done the standard thing with them and then enhanced it or changed it with these tests, and then looked at long-term outcomes. Instead, these tests are all, oops, sorry, my mouse is sensitive. These tests are all correlative tests. In other words, they've done these tests and they've correlated the outcomes. And those correlations are not necessarily causations, and they're not proof that the whole concept is effective. But in the absence of anything else, they may help us to make these decisions. Okay, here's, before we get into this big list that I got in the background, I just want to remind you that the positive predictive value, and what this means is if you're undergoing a prostate biopsy, what's the likelihood that we'll have cancer, that we'll be able to detect cancer with that biopsy? Well, if your PSA is above 4, and I think the slide is a little erroneous, that positive predictive value is about 30%. Turns out if it's above 3, it's about 28. So between 3 and 4, it's about 28. This is not very good. This means that if 10 guys go through prostate biopsy with a PSA above 4, 3 of them are going to find cancer and 7 are not. And this can lead to a lot of excess biopsies. And so most of these tests that you see in the background are designed to sort of help that or augment that. They want to increase that positive predictive value and make it higher. I sort of decided I'm not going to go into detail about all of these tests. Many of these tests incorporate your PSA history. They look at free PSA, intact PSA. Most of these are labeled as genetic tests. And you can see, they got names like Genetics Institute of America, Genesis Genomics, things like that. But to be honest with you, most of these tests do not look at specific prostate cancer mutations or prostate cell mutations. Instead, they look at downstream products of that. So in other words, if you've got more, some of this human kallikrein, that can enhance our ability to decide you're more likely to have prostate cancer on a biopsy. If you've got this T2 ERG fusion, and PCA3, that can enhance it. And so they look for the products of those genes in most of these cases. The one thing I will talk to a little bit about at the bottom here, because this is kind of a cool concept that I think is going to become more and more used, is this thing called single nucleotide variants, otherwise known as SNPs, SNP, which is single nucleotide polymorphisms. This is where the DNA for a single, for a single part of a protein is damaged or different. And the way they identify these is they kind of come up with what a normal nucleotide should be in a gene. And then they test to see if you've got an abnormal variant for that one amino acid. And if you have that, that may put you at increased risk. And now they have the ability to look for these pretty easily. So they're building big libraries of these, and they're trying to correlate those libraries with outcomes, like who gets prostate cancer, who dies from prostate cancer, who gets different types of cancers. And there are now labs out there who will test you sometimes for free because they're trying to build their library. And as the library gets bigger and they're able to correlate, then they can find out differences, and they'll tell you about those issues. Okay, again, correlation is not causation. So none of these enhanced screening tests have proven any benefit, any long-term benefit, like prostate cancer survival, how long you live, toxicities, pain, any of that stuff. Now, just because they're not proven doesn't mean there isn't a benefit, but it doesn't mean there is a benefit either. So these really need to undergo increased testing, and there are multiple clinical trials out that are looking for them. And again, most of these are not directly testing for genes. They look at proteins, mRNA, antibodies, things that are downstream products of those genes. They're typically labeled as genes because, again, as we discussed at the beginning, genes are powerful. And so they want to sort of harbor that power when they're marketing this to you. And in a sense, they're correct because, you know, the genes are what make the proteins. They're the ones that make the messenger RNA. They're the ones that ultimately can make antibodies. But just keep that in mind. And it is important to realize that none of these have been proven. And that's why none of them are regularly used. In other words, they're not like, if you've got a PSA, we automatically do this test on you. If your PSA is above 4, we're automatically going to do this test on you. We don't have that out there yet. So in other words, some people may elect to do this test because it may help us with our decision-making process. This is highlighted if you look on the NCCN website. They say all of these are category 2A. And that what that means is these look like they can be very beneficial for people, but they're not giving them category 1 because they haven't been proven in a clinical trial. And so they say best management of any patient with cancer is in a clinical trial. So they want you to participate in those clinical trials so we can prove that this stuff is actually beneficial. Okay, back to our timeline again. Testing to enhance prognosis or treatment choices. So that whole list that I gave you before, that can be used to look at active surveillance. And many of those commercial products will have recommendations where they say, oh, you know, your risk of having a high grade prostate cancer or a high risk prostate cancer is low, you know, and so as a result, we think it's, you know, active surveillance seems to be a good choice. Or the opposite, it looks like this is a high risk prostate cancer based on the results of these tests, so maybe we should do treatment. So keep that in mind. But where we're doing an intervention here is, of course, you've had the biopsy and now we're saying, hey, is this thing really aggressive? What should we do as far as definitive treatment? Or, you know, you've been on active surveillance and we do this test and we say, oh, maybe we should do definitive treatment. Almost all of these types of tests are done on the prostate biopsy specimen, and they're looking for specific genes that correlate with adverse outcomes or more aggressive cancer or things along those lines. Again, there are multiple of these. I only put 4 on here because these are 4 common ones. The 2 most common ones are the Decipher and the Oncotype DX, but there are others out there. It's a big marketplace for these things. So here's kind of some more testing scenarios. Let's say you've got a prostate cancer and you've, you know, by biopsy, and you're saying, I think I'm going to do a prostatectomy. Well, one of the things about doing a prostatectomy is after we've done the prostatectomy, and this is actually a big benefit of doing the prostatectomy, is we get to look at the pathologic specimen. In other words, we get to analyze your prostate because we've removed it from your body. And we can look for adverse features. And it's been proven in randomized clinical trials that these adverse features will result in us recommending adverse radiation therapy with or without hormones if you have some of these adverse features. So if you're undergoing a prostatectomy, if there's a way where you can predict whether you have these adverse features, that may change your mind about undergoing a prostatectomy. Instead of undergoing a prostatectomy, you may decide to do something else. For that, Oncotype has been used for this specific scenario. We do the Oncotype here, and they say, oh, you've got a high risk of having adverse features. Well, then maybe that might change your decision and you decide to do radiation or some other type of treatment. So that's one place where we can use it. The other place we can do it is, let's say you got a patient and this patient has, you know, an elevated PSA. They've had benign prostatic hypertrophy for numerous years. You know, they got a big prostate. PSA has been going up slowly. They've been doing active surveillance, and all of a sudden their PSA is like just over 20, right? But otherwise, all of their risk factors are low risk factors. You know, the Gleason score is 6. You know, they don't really feel anything adverse on the digital rectal exam, or even an MRI doesn't look that bad. how do we treat them? Do we just give them prostate radiation? Do we give them prostate with 6 months of hormone therapy? Or do we give them prostate radiation with 24 months of hormone therapy? How do we manage this? Well, right now, the standard answer from a radiation oncologist, the standard of care answer would be, your PSA is above 20. That makes you a high risk patient. That means you got to get 24 to 36 months of hormone therapy. Now, there's wiggle room in that. It kind of depends upon toxicity, age, a whole bunch of other different factors, patient choice. But is there anything that could help us to make that decision? Well, the Decipher guys say, hey, if you do our genetic testing, we can tell you whether this thing is more high risk or less high risk, and therefore you can tailor your treatment or tailor the amount of hormone therapy that you need to use in order to sort of optimize care. Back to that precision medicine term again. So maybe we can say, hey, your Decipher score is super low. Maybe we don't even need to give you hormones, right? Again, none of these things have been tested in that way. And so we don't know for sure that that's the case, but we do have correlation, and maybe that can help you make your decision. Okay, the last group that we're going to deal with here, again, back to our prostate cancer timeline, is this group over here. This is after you've had definitive treatment, and we're looking at your prostate cancer's coming back, your PSA's going up, or we see, metastasis on imaging scans, or you've got, castrate-resistant prostate cancer, like we've had you on hormone therapy, and the hormone therapy isn't working anymore, and we've done treatments with enzalutamide or apalutamide or other second-line agents, and those aren't working. Is there something we can do that's tailored to that? And this is where we get into sort of the PARP inhibitors. So I think I've got a slide on here that discusses the PARP inhibitors. So PARP inhibitors are related, mostly seem to be effective in people who have mutations in their repair enzymes. So there are repair enzymes that repair the breaks in DNA. And these are what get mutated in BRCA mutations. This is homologous repair. And so if you have mutations in those enzymes, then these PARP inhibitors can be effective in treating your prostate cancer. And what they basically do is they block the attempted repair of these breaks in your DNA in the DNA of the cancer cells, and they inhibit this so that you can't repair it, and that leads to more apoptosis and death of cancer cells. These have actually been tested in people that have BRCA mutations. They've used olaparib in metastatic castrate-resistant prostate cancer. These are two survival curves. The red curve is without the medication with the control group, the placebo group. And the blue line is with the olaparib. And this is image-based progression-free survival, which you can see here. And this is overall survival. And as you can see, the overall survival is a little enhanced. Towards the bottom here, they kind of come together. But in this area, you can see this group is doing better than that group. As a result, if you happen to have a BRCA mutation, and this doesn't necessarily mean you've got a BRCA mutation in your germline cells, you can actually end up getting with BRCA mutations in your prostate cancer cells, even though you don't have a BRCA mutation in your germline cells. Normally, it's in the germline. So most of the time, we're seeing this in germline patients. And so germline testing is generally done for these patients. And if they've got a BRCA mutation, then they could be a candidate for olaparib therapy. Just because you got a BRCA mutation doesn't mean you're necessarily going to have one of these, but it is an option for treatment in this area. Okay, last, I'm going to put in a plug for a clinical trial. So if you'll remember up here, we had this Decipher right here to help us sort of make decisions about how to tailor our treatment with hormone therapy. There's actually a national randomized study that's looking at using this. And so this is going to use the Decipher test. We're going to use that on your prostate biopsy. This is for high-risk prostate cancer patients. High-risk prostate cancer patients, meaning someone with a PSA above 2, a Gleason score of 8, 9, or 10, or there's evidence of extracapsular extension or seminal vesicle invasion on digital rectal exam, and I think maybe even on MRI in order to participate in this study. And what they're going to do is they're going to, take you into the study. They're going to give you this Decipher test. If your Decipher score is less than 0.85, you go into this group. If it's greater than 0.85, or you got evidence of nodal involvement, lymph node involvement in the pelvis on imaging studies, then you go into this group. This is going to be the de-intensification group, which means that if you get randomized to the experimental arm, you're going to get radiation with just 12 months of hormone therapy. Otherwise, you get the standard of care. On the other side, if you've got a more aggressive looking prostate cancer, then you're either going to get the standard arm, which is radiation and 24 months of hormone therapy, or you're going to get 24 months radiation with 24 months of hormone therapy with either apalutamide or abiraterone on this treatment. So this is actually intensifying the treatment, and this is actually de-intensifying the treatment. So these are the experimental arms, arm 2 and arm 4, and we're going to compare those results with arm 3. And the thought is, with this Decipher, we're going to do a better job of treating these arm 4 people, and we're going to do the same job of treating these arm 2 people, and these guys get less hormone therapy, and these guys have to have more intensified treatment. Okay, I think we got some questions. I'm going to look at those questions right now and try and answer them as best I can. Happy future Turkey Day to all you guys out there. Is this germline testing similar to what I recently read about a blood test developed by the Mayo Cancer that can help screen for certain cancer types? Yeah, so Joseph Bednarski, I got to tell you, I don't know. I need more information. The Mayo Clinic comes up with tons of different types of tests. And there's blood tests these days where we can actually look for circulating cancer cells. There's blood tests where we can look at your genes to assess your genes to see if there's mutations in your genes. They're doing those blood tests to develop those SNPs that I told you about. And then they look at your library of SNPs and they can tell whether you have certain cancer types. We also are commonly using blood and catching those circulating cancer cells to look for the mutations for specific types of cancers, or for specific mutations in cancer that may be amenable to therapy. So for example, this is done commonly in lung cancer. So in lung cancer, rather than doing an invasive test to try and get more of your lung cancer, they just test your blood and they can say, hey, you've got this mutation and we've got this drug for this mutation that has excellent results. Does UNMH do enhanced screening? In other words, do we offer tests like the 4K test in order to decide whether or not we're going to do a biopsy? Mr. York, I would say we probably do. I think we have done that in the past. I'm not sure how much it's used. The urologists I have seen the urologists do this in the past. I don't know how often they do that. I'd have to talk to our urologist to see how often that they do that. And then Phil is asking me an even worse question, an even harder question, which is, at what age does NCCN recommend PSA screening? Whew. So that one's tough. It's kind of tailored, depends upon whether you got a family history positive. And I don't know if they stick to the party line, and the party line is depending upon which party you're in. There are still groups out there that say that PSA screening has not been proven to decrease mortality. And so because of that, you don't have to do PSA screening. And there is some evidence that suggests that group is right. There's also some evidence that suggests that group is wrong. There are still some trials out there being done, like the PROTECT study, which is looking to see whether PSA screening works or not. To be honest with you, I don't remember what the NCCN says. It's not that hard to find, though. You guys, you can look it up on your own and see what they say. I think it's a good idea to do prostate screening. I think if you've got a family history of prostate cancer, you might want to start that in your late 40s. And I think after that, you should be doing it in your 50s and 60s. How long to do it, I would say, depends upon what your PSA is and how long you're going to live. If you're looking good and you're 70, I still think it's a good idea to do it, even if you're looking good and you're 75, because sometimes bad prostate cancers can come out late. We just got to be careful about how we make decisions about whether to get a biopsy or whether to engage in treatment. I think there's a history of over-treating prostate cancer, and some would say a history of over-diagnosing prostate cancer. I don't particularly care for that term, overdiagnosis. I think just because you diagnose somebody, you don't have to treat them, and you can watch them. So I'm all for diagnosis, but that exists out there, and so I don't know where that is. Should almost all prostate cancer patients get some genetic testing? I think the answer, this is for Woody, the answer out there is, at this point, no. We don't think all prostate cancer patients should get some kind of genetic testing. I think it's going to depend upon your family history, how aggressive your prostate cancer is, where you are in the prostate cancer spectrum. Like if you're a prostate cancer patient and you had a prostatectomy 5 years ago and your PSA is undetectable, there's no need to get any genetic testing. You just need to continue on with observation. But there are increasing scenarios where this is going to happen. And I think, Woody, in the future, genetic testing is going to be just common, where we're testing everybody to assess their risks, and it'll be increasingly complicated. When is an SPSA test used? So anonymous attendee, I got to tell you, I'm not exactly sure what you mean by an SPSA test. I don't know if that just means a serum PSA test. So I will have to look that up to see exactly what's going on. And then finally, I made it to Hank. Hank's had PSAs that are going up, and he's had multiple biopsies that are negative, and he's wondering what's the logical next step. His PSA is now up almost to 20, and he's 75. Hank, I think at this point, your biopsies are missing because you've had 3 negative biopsies, the latest in 2021. My guess is that we should probably do some imaging tests on you. My recommendation would be to do a multiparametric MRI to see if we can identify a lesion in the prostate that is consistent and can be used to sort of target the next biopsy, and we can figure out what's going on. I think with your PSA continuing to go up that high, it is very worrisome for prostate cancer. While observation I don't think is wrong, I think it still would be a good idea to do some imaging tests to see if we can enhance targeting of those biopsies.
In men under the age of 40. So the panel does not recommend routine screening in men between the ages of 40 to 54 years. At average risk, this means you're a man who does not have a family history or is African-American race. For men less than 55 years at higher risk, that is a positive family history or African-American race, decisions regarding prostate cancer screening should be individualized. So that's a shared decision between the clinician and the patient. And the panel strongly recommends shared decision-making for men between the ages of 55 to 69 that are considering screening for prostate cancer. And I'm sorry, this should be based on a man's preferences. So if you look at the overall benefit, it appears to be between the ages of 55 to 69 years of age. If you're average risk and you have a normal screening, then really a routine screening interval of 2 years or more may be preferred over annual screening in those men who participated in the screening process. And the panel does not recommend routine PSA screening in men over the age of 70 or any man with a life expectancy less than 10 to 15 years. So some men 70 plus years who are in excellent health may benefit from screening. They're not saying you just don't screen those men, but you have to, once again, look at a man's overall health and life expectancy. The reason for not screening men over the age of 70 years is because there's a higher risk of overdiagnosis of a low risk prostate cancer and competing medical problems that may not give any benefit in diagnosis of a prostate cancer. And there's also clinical trials that don't show a proven benefit, but these trials really weren't powered to look at this age category. And there's a lack of proven treatment benefit with patients who have a less than 10 to 15 year life expectancy. But on the other hand, in men who are 70 years or above, there are some strategies that can be used. One of those is if a man is screened for some reason and has a PSA greater than 10, really this can be a sign of more aggressive prostate cancer. So those men probably should have a prostate biopsy. The PIVOT trial showed that men with a PSA greater than 10 had a decrease in all-cause mortality at 10 years after surgery, and those men were almost 70 years old. And really, if you have a PSA and you're above the age of 70 and it's less than 3, there's really no reason to continue screening lifelong. The probability of prostate cancer death is very low. It's 1 to 3%. The two screening trials that have been given us data are the, I'm sorry, I just lost my cursor here, are the ERSPC and the PLCO screening trials, the European randomized study of screening for prostate cancer and the prostate, lung, colon, and ovary trial. These were developed because older studies in support of screening were criticized for poor methodology. So that's the reason these trials were created. The ERSPC was a randomized trial of PSA testing in 8 European countries that enrolled a large number of men. And the finding was that prostate cancer specific mortality was significantly lower in the screened arm. There was a benefit which increased with time, and it also demonstrated a much lower risk and spread of prostate cancer at 9 to 11 years. The PLCO trial was not as good as the other trial. It enrolled about 77,000 men, and they were randomized to PSA screening or prostate cancer testing for 6 years and DRE for 4. At 13 years, there was about a 12% increase in prostate cancer diagnosis in the screened arm, but they did not find a difference in prostate cancer death between the two groups. There was a lot of criticism about this trial because of the contamination in the trial. So if you look at the bias and contamination in these two trials, in the SPC trial, it was about 20 to 25%. But in the PLCO trial, it was very high. And this likely contributed to the lower than expected number of deaths in both arms in the trial because you're comparing screened men to screened men due to contamination. So if you look at this, or the contamination and bias in these trials, basically, including the 10% of control participants with baseline PSA screening contamination, the proportion of participants who reported having undergone at least one PSA test before or during the trial was close to 90%. So it was a very high contamination. And these trials also showed that the number needed to screen and to diagnose to prevent one prostate cancer death was pretty high. And this was another argument that screening really wasn't the greatest thing to perform. So when we look at PSA screening, what are the harms of PSA screening or screening for prostate cancer? Well, obviously you have to undergo an invasive test, a prostate biopsy, and this has risks, including blood in the urine, blood in the stool, blood in the ejaculate, painful urination, urinary retention, or the inability to urinate, pain and infection. Blood in the urine and blood in the sperm are the most frequently observed side effects. And blood in the sperm after biopsy occurs in about 10 to 70% of patients. Blood in the urine is seen in a high proportion of patients, 14 to 50% of the time. These are usually self-limited. Blood in the ejaculate basically can go on for weeks, even months at times. So while the risk of hospitalization due to a complication remains low, infectious complications, unfortunately, in the United States are increasingly steadily over time. And this is usually, or is possibly due to fluoroquinolone resistance and poor antibiotic stewardship. But the 30-day risk of hospitalization after a biopsy for any cause has been estimated to be about 4%. So the risk of prostate biopsy overall is about 4%. Most of these are infections. And some practitioners will use fecal culture and sensitivity to tailor an antibiotic approach for prostate biopsy. And obviously the other harm is risk of overtreatment of low-risk prostate cancer due to the assumption that the diagnosis with a cancer must necessarily result in treatment. And this was seen in the 1990s that about 1 in 4 patients with a diagnosis of prostate cancer may have been overtreated. So really, you'll hear this a lot probably from myself and other panelists today, but shared decision-making is encouraged in prostate cancer screening and deciding about a prostate biopsy. And this is a decision between the clinician and patient, the clinician going over the risk, benefits, and alternatives. But patients are encouraged to decide for themselves whether the benefits of screening outweigh the harms. Patients and clinicians should engage in shared decision-making when initially discussing screening, as well as subsequent screening discussions. And so for men at average risk, some clinicians don't recommend in favor or against screening. Other experts, advise screening, especially for high-risk patients. Those are the patients really that obviously should be screened, but it's essential with either approach. So useful points for this discussion is that a prostate biopsy is an invasive test and is needed to determine whether prostate cancer is present. Biopsies can rarely cause serious infections or other complications. Even if a man has a prostate cancer, a biopsy may miss finding it, and this is something that I have seen in my practice. Patients who choose to be screened with a PSA test are much more likely, obviously, than those who decline screening to be diagnosed with a prostate cancer. Many prostate cancers detected by screening are considered overdiagnosed, meaning that they won't cause any problems during a man's lifetime. And men with prostate cancer, most will die from other causes, not from prostate cancer. Not saying prostate cancer is an insignificant disease. This is just kind of the data that we know. So another point to make is no available test can accurately determine which men with a prostate cancer found by screening have a cancer that's destined to cause death. And surgery and radiation therapies, which are treatments for prostate cancer, and the most common treatments offered, have side effects and complications, including urinary incontinence, sexual dysfunction, and bowel problems. So moving on to prostate cancers, once it's diagnosed, Epstein came out with the grading group, and this is kind of has been out since 2015, but helps to risk stratify prostate cancer. I'm sure you're all familiar with of Gleason scoring or grading, and grading is just the kind of aggressiveness of the cancer. And so if you look at the grade groups, there's grade 1 is Gleason score 6 or less, grade 2 is 3+4, grade 3 is 4+3, and 4 and 5 are the higher risk, grade 8 to 10. And this is what urologists really do. We basically, once the diagnosis is made, we have to decide on additional testing and then have a management discussion followed by treatment and then surveillance in some cases. And after treatment, this algorithm just goes through what is the most routine surveillance after treatment for prostate cancer, after surgery, radiation, or surveillance, which is also known as watchful waiting. So if you look at the risk stratification for localized prostate cancer, these are the guidelines from 2017. The 3 professional societies, the American Urologic Association, ASTRO, which is a radiation oncology group, our association, and the Society for Urologic Oncology, risk stratifies patients into very low risk through high risk. So if you look at the very low and low risk, these are patients who have usually grade group 1 or Gleason 6 and lower, and a PSA less than 10. Intermediate risk, you have favorable and unfavorable risk disease. Those are patients who have a PSA between 10 and 20, or a grade group with a 3+4^7 or 4+3. I'm sorry, that's the unfavorable. And the in the unfavorable grade group is 2 with a PSA between 10 and 20, or grade group 3, which is 4+3 with a PSA less than 20, and high risk is anybody with a Gleason score 8 to 10. So in these categories, in very low and low risk, once again defining them, very low risk is a PSA less than 10, Gleason sum 6, less than a third of biopsy cores positive. And low risk is a PSA less than 10, Gleason sum 6 or below in a clinical stage T1 or T2A. This means it was diagnosed either on a TURP or prostate biopsy. And the recommendation is that these patients really do not need more testing in these low risk categories. So they don't need an abdominal pelvic CT, they don't need bone scans, because it's very unlikely that they will have any evidence of spread of disease. And really the recommendations now for these patients is that active surveillance in these patients is the preferred treatment. So in very low risk, it's the best available care option, and in low risk, it's preferred. Obviously, clinicians can offer definitive treatment for patients in the low risk category who have a high probability of progression, or also patient anxiety sometimes will make a patient want to make a decision to pursue treatment. And I've had patients like that who are just very anxious because they've seen a relative die of prostate cancer, and so they just want some type of treatment even though they were diagnosed with low risk disease. Clinicians should not add androgen deprivation therapy if a patient chooses radiation therapy, except to reduce prostate size, such as for brachytherapy. Also, clinicians should inform patients considering freezing of the prostate or cryosurgery that side effects are considerable and survival benefit has not been shown compared to active surveillance. And then for high intensity focused ultrasound, these inventions are not, it's not standard of care because outcome evidence is lacking. And really we base our recommendations on evidence-based care. So clinicians should recommend observation or watchful waiting for men with a life expectancy less than 5 years with low risk prostate cancer. And this is really true of any risk prostate cancer. And among those with the low risk cancer, tissue-based genomic markers have not shown a clear role in selections of candidates for active surveillance. So this really is not something that needs to be pursued. Moving on to intermediate risk. So of course, as I stated, we have favorable and unfavorable disease in intermediate risk. The favorable is 3+4^7 with a PSA less than 10, or Gleason sum 6 with a PSA between 10 and 20. And the unfavorable is 3+4^7 with either a PSA between 10 and 20, or a 4+3 with a PSA less than 20. So you should have imaging to evaluate for spread of disease and unfavorable risk. That's the 4+3 or 3+4 with a PSA between 10 and 20. So this could be either a CT or MRI of the abdomen, pelvis, and a bone scan, and that's just looking for metastatic disease in the lymph nodes or the bones. Standard treatment, clinicians should recommend radical prostatectomy or radiation therapy plus androgen deprivation therapy. That's hormone therapy, as sometimes it's called. And this is standard treatment options for prostate cancer with intermediate risk localized prostate cancer. This is a strong recommendation with evidence level grade A, which is the highest evidence level that can be given. Alternative options, you should inform patients with favorable intermediate risk prostate cancer. They can be treated with radiation alone, but the evidence basis is less robust for benefit than combining it with hormone therapy or androgen deprivation therapy. So it's something that, once again, is a shared decision between the patient and clinician. In select patients with intermediate risk localized prostate cancer, patients can consider freezing or cryosurgery. And active surveillance may be offered to select patients with favorable intermediate risk localized prostate cancer. However, patients need to be informed that there is a risk of developing spread of disease when this is performed. Clinicians should recommend observation or watchful waiting for men with a life expectancy less than 5 years, and basically should inform patients that high intensity focused ultrasound is not standard of care, and there's no comparative outcome evidence with this form of treatment for intermediate risk prostate cancer. Finally, high risk prostate cancer. So there's no favorable or unfavorable high risk prostate cancer. Obviously, the name high risk means it's high risk, and this type of disease needs to be treated. All these patients should be staged with cross-sectional imaging that's either a CT or MRI and a bone scan. Clinicians should recommend radical prostatectomy or radiation therapy plus androgen deprivation therapy as standard treatment options for patients with high-risk localized prostate cancer. Usually androgen deprivation therapy and radiation therapy, the androgen deprivation therapy is for 2 to 3 years. And this is based on grade A evidence-based medicine. Let's see here. Clinicians should not recommend by any means active surveillance unless a man has a life expectancy of less than 5 years. Cryosurgery and focal therapy and HIFU treatments, meaning high intensity focused ultrasound, are not recommended outside of a clinical trial in these circumstances. And you really should not recommend primary androgen deprivation therapy unless the patient has both limited life expectancy and local symptoms. So androgen deprivation therapy and localized high-risk prostate cancer should be combined with radiation therapy in most circumstances, if that's what the patient has chosen. And really with these high-risk patients, consideration should be made for genetic counseling, especially in patients who have a strong family history of specific cancers, that is breast, ovarian, pancreatic, or other gastrointestinal tumors, including lymphoma. So to conclude my talk, really the role of the urologist in prostate cancer is to counsel patients about the pros and cons of screening, perform prostate biopsy to confirm or exclude a diagnosis of prostate cancer, counsel patients on risk stratification after the diagnosis, and then perform appropriate imaging if that is indicated based on their risk category. Really engage in a shared decision-making conversation for best treatment options, and this includes, from screening of prostate cancer down through treatment options, and decide what the patient is most comfortable with in terms of treatment after diagnosis. And then once treatment has been performed, engage in appropriate surveillance and try to treat or mitigate the side effects and complications of treatment if possible. So let me see if I can find my cursor again. So I appreciate your time this morning, and thanks for letting me participate. And now I'll stop sharing my screen. Thank you.
Thank you, Dr. Davis. Let's see. Okay, I guess you can all see me now. Dr. Davis, if you could stay with us or at least come back in about 40 minutes to answer questions, we would really appreciate that.
Yeah, no, I'll stay on. Thank you.
Thank you. Our next speaker is Dr. Heyoung McBride. She's the medical director of radiation oncology at Loveless Cancer Center, and she's also the co-medical director of Gamma Knife Center of New Mexico. She's got a broad and deep experience in all aspects of radiation oncology, both in community private practice, academic medicine, and currently within a hospital system. She has her medical degree from the University of Kansas School of Medicine in Kansas City. She had an internship at Northeastern Ohio University and in radiation oncology, University of Arizona Health Sciences Center, the Department of Radiation. Dr. McBride, if you would turn on your camera and your microphone. Great, there she is. And I'll turn it over to you.
Yeah, this is going to be an experiment because I wanted to start out with a slide that says, I quote Mark Twain. It says, "It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so." So if you can, this I think applies to a lot of what happens in radiation oncology. I'm in prostate cancer from genetic testing, which Dr. Schroeder gave an excellent talk to screening, to treatment decisions, and recurrence management. For those of you who are new to this whole journey, what is prostate gland? It's a walnut-sized gland that sits just below the bladder in front of the rectum. And it surrounds the urinary tube that comes out of the bladder out to the penis. And it produces about 1/4 of your seminal fluid during ejaculation. And the prostate cancer is #1 cancer in US males. So if you are a male living in this country, your chances are about 1 out of 6 during lifetime. But the good news, as you have gleaned from excellent presentation by Dr. Davis and Schroeder, is that overall survival rate at 5 years is close to 100%. However, there are those cancers that are extremely aggressive and life-threatening, and those are the ones that we unfortunately see often as well. The prostate cancer usually is adenocarcinoma, which is almost all of them. Occasionally, there are other rare types of cancers, and they are actually a whole lot worse than ordinary adenocarcinomas, such as small cell carcinomas of the prostate are very bad. And one of the pitfalls about prostate cancer screening with PSA, it is good for generic prostate cancer, but there are prostate cancers that do not produce the PSA. PSA stands for prostate-specific antigen, which is a protein that's made only in prostate gland, or cancers of prostate that starts from the prostate gland, and they can produce PSA at a more increased rate, which makes the PSA go up generally. However, the most aggressive prostate cancers, absolutely the worst, are the ones that do not make PSA. And they're the ones that are most serious and most life-threatening. So just a word of caution there. You're at higher risk if you are a male in the US and you have a family history with 1 first-degree relative, you have twice the risk. If you have 2 or 3 first-degree relatives with prostate cancer, you have 5 to 11 times the risk. It's related to number of relatives and age at diagnosis when they were diagnosed. But 90% of the prostate cancers are sporadic. So the question that we all want to know is, how can we prevent this? Can we prevent prostate cancer? There's really no sure way to do that. You can't control your age, your race, your family history. You don't get to choose your own family. Lifestyle that might lower risk of prostate cancer is the same kind of a diet that is heart healthy. And lifestyle that is generally heart healthy. In other words, eating lots of fruits, fresh fruits and vegetables daily, and being physically active and maintaining healthy weight, not skinny, just healthy. There have been a lot of interest on supplements. If you go to health food store, they'll tell you all kinds of things will lower the risk of prostate cancer. There were large studies that were done for vitamin E and selenium supplements, and they were negative. And the other things you can do are, again, if you think a heart healthy lifestyle, don't smoke and exercise regularly and maintain healthy weight. And this is also very important. If you happen to be diagnosed with a prostate cancer and you're going through treatment, you'll be able to tolerate it and will feel better if you don't smoke and stay active, physically active. And I was just going to show you the SELECT study that showed that there was no benefit That was vitamin E and selenium. And Dr. Davis did a really good job of reviewing the overall prognostic factors, stage, Gleason score, PSA, molecular profile, age, and health. And as far as treatment, you'll, again, the shared decision-making, you want to discuss with your doctors. The overall outcome between radiation therapy and surgery are very similar. Radiation oncologist, Dr. Schroeder and I are radiation oncologists. We are cancer doctors who specialize in treating diseases with radiation therapy. Then you have the urologist who's surgeon, the medical oncologist who specializes in treating cancer with the medications and chemotherapy. There are bewildering numbers of treatment options, from observation to all kinds of radiation therapy, active surveillance, and you've heard a little about HIFU and cryo, brachytherapy, prostatectomy, chemotherapy, and et cetera, SBRT, IMRT, and so forth, and of course, proton. The main advantage of radiation therapy over radical prostatectomy is that the cancer that's right at the edge of the capsule of the gland and just a little bit beyond. Radiation therapy is very good at being able to cover that. For surgeons, this is a difficult area to cover. In other words, the cancer right along the edge, because the radiation therapy field extends about 5 millimeters around the prostate, which makes it easier to cover. When I was at one of my former academic institutions, my chair used to, apologies to Dr. Davis, used to kind of nickname nerve-sparing prostatectomy intended to improve the odds of patient not becoming impotent after prostatectomy. He used to call it cancer-sparing surgery, just because of the microscopic prostate cancer that can be just outside the neurovascular nerve bundle around the prostate. There are many different ways of prostate cancer treatment with radiation. There are machines, there's a radioactive seeds, there's a radioactive isotopes. It can be combined with a hormone therapy, combined with immunotherapy, combined with surgery. It can be for curing, it can be for symptom relief. And I had all these nice pictures of radiation therapy machines, which unfortunately I can't show you right now. And then also how the seed implant is done. And the way we do the radiation over the last 10, 15 years, or ever since beginning of the field, has evolved tremendously, especially in the last 10 to 15 years. I sort of think of it as a pace, if you think of the evolution of computer technology and software and hardware, that has influenced radiation therapy technique and our ability to conform the radiation therapy fields just to where we want to and save everything else at a much more efficient rate, which has resulted in improved cure rate and decreased complication after radiation therapy for prostate cancer. One of the things we've also been able to do more recently to decrease rectal complication of radiation therapy is placing a spacer. In other words, just there is very little space in a normal anatomy between the back of the prostate and front of the rectum. And we would put in a little biodegradable buffer. And so this has been consistently shown to decrease most common potential risk of radiation therapy, which can be rectal bleeding. And I had a nice picture of myself with a colleague when I was visiting one of the centers for proton therapy, because I figured that this group would be interested in hearing about that, as you have all read the local newspaper a couple of weeks ago. So the concept of proton therapy was initiated, well, in the interest of time, I will move that along. The proton dose distribution as it enters the tissue has a very low entrance dose at the beginning, at the very first part of the tissue. And then there's a thing called a Bragg peak where all the radiation dose is dumped. And that's the main advantage. However, in order to treat this to cancer, you have to have a whole bunch of radiation beams to do that, and to cover the prostate cancer, to cover the tumor, and that includes prostate. And there has been, I had some recent trials, reports that just came out in the last few months comparing various types of radiation therapy, including proton therapy, protons, photons, SBRT, brachytherapy. Really, if any of those are done well, the outcome is very comparable with no particular advantage on one or the other in terms of cure rate or side effects. And if man is at risk of local failure after surgery, as Dr. Schroeder talked about, I would recommend that we start the radiation therapy earlier rather than later, and there's good evidence for that. And just before I close, one thing I want to point out is that one of the more recent development is for patients who have metastatic prostate cancer. There's a concept called oligometastases, which means limited amount of cancer that's spread beyond the prostate. And those patients seem to have much different outcome, and the behavior seems a lot different than those patients with a widespread disease. And many of those we're finding are potentially curable if we address those sites of oligometastatic disease. And the bottom line, all treatment can fail at some times because of biology of the cancer. All local therapies, either surgery or radiation, can fail because cancer spreads. And Dr. Avitia will talk about that. So the radiation therapy is an important and integral part of care of all of you with prostate cancer at every phase of your care. And it is critical to have a multidisciplinary team to help you coordinate and recommend optimal care. And so we have come a long ways, but we still have a lot of ways to go.
I'm going to go ahead and introduce Dr. Avitia. Dr. Avitia is a board certified medical oncologist. He serves as the principal investigator of the prostate cancer trials at the New Mexico Cancer Center and works in collaboration with the X-Cancer to bring innovative clinical trials to New Mexico. He received his medical degree from the University of Illinois in Chicago. Dr. Avitia has completed his internal medicine internship at the University of New Mexico and medical oncology fellowship at University of Oklahoma. It says here that Dr. Avitia is a strong advocate for patient access to education, as so are we here at the Prostate Cancer Support Association. Dr. Avitia believes prostate cancer patients should have world-class care here in New Mexico. He was born and raised in Grants, New Mexico, and plans to serve his beloved state for years to come, and we really appreciate that. Dr. Avitia, I'm going to go ahead and turn it over to you. Thank you.
Well, thank you for that introduction. I appreciate it. So let me just share my screen here. So here's just some review slides, as I'm sure most of us have already gone through this through other presentations, but it is the leading cause of cancer in men is prostate cancer. It's second in terms of deaths. Since the implementation of PSA screening, here there was a few cancers diagnosed because of the lack of screening. Once we introduced the PSA antigen, as we can see here, the diagnoses went up, but as we became stricter with criteria, you can see that there was a decline here in the amount of diagnosis. And the great news for prostate cancer, it's here in this brown line. Is kind of hard to see, but as you can see here, you start to see a decrease in mortality. So there's less deaths related to prostate cancer. And a lot of this is because of the new and novel treatments and better surgical techniques, better radiation techniques, and obviously patients are living longer because we got better drugs and better options for patients. Here's some of the risk factors that my colleagues already talked about. Age, the median age for someone with prostate cancer is 65 years of age. We know that race and ethnicity plays a role in terms of an individual's risk. So African Americans, as you can see here, have a much higher incidence, a much higher risk of death here. About 5 to 10% of these are familial, and patients who are at risk are either patients who have a brother or father or multiple family members who have been diagnosed with prostate cancer who are younger than 60 years of age. We know that there's some genetic mutations in the germline repair genes, such as BRCA1 and BRCA2. Lynch syndrome is a syndrome where you have one or more family members with colorectal, endometrial, gastric, ovarian, or pancreatic, small bowel, urothelial, or kidneys. Ashkenazi Jews have a higher increased risk of developing prostate cancer. So we do recommend referring these patients to genetic counseling to get germline testing. As Dr. McBride alluded to, the diet is a risk factor. Animal fats have been linked to that. So trying to reduce your consumption of red meat and animal proteins to at least once a week would be advisable. And obviously increasing the fruits and vegetables and exercising, since we know that obesity is associated with a higher increased risk of aggressiveness at diagnosis, but not a risk of diagnosis. We know that vasectomy and smoking are actually not considered risk factors for this disease. Just a review of what Dr. Davis has already talked about. 95% of cancers are adenocarcinomas, and we grade these through a Gleason score. Up here, less differentiated cancer. Down here, the more differentiated. And so the Gleason score, if you have, say, here, a 3 as your predominant tissue type in your prostate, and then your second most predominant is a 4, and that would give you a Gleason score of 7. And so this is a grading system that we use at diagnosis. As Dr. Davis said in his presentation, there's the different Gleason groups, and these correspond with risk of recurrence here with grade 1, the least likely to recur. And as you go down the line to group 5, you end up seeing higher risk of recurrence in these patients in distant disease. I am a medical oncologist, so I don't have any fancy machines or surgical technique, but we do use very advanced drugs and hormone blockage to treat prostate cancer. So I'm going to go over a little bit of that right now. So this is the androgen axis. As you can see here, here's the pituitary gland, and this pituitary gland sends signals down into the testes to produce testosterone. And so 95% of our testosterone comes from our testes. And so we want to be able to block this because the testosterone actually feeds the cancer and proliferates the growth. So we want to block this axis here with androgen deprivation, or ADT. And so we use these agents here. which block here at the pituitary gland, which block the signal here from going to the testes. And when you don't have that signal going to the testes, you're not producing testosterone, and that's not feeding the prostate cancer, as we can see here. But we also have to cut out other sources of testosterone, because we want to make sure that our testosterone levels are less than 50. And so another source of androgen source is the adrenal glands here. And so we have drugs that can block the production of sex hormones. And so we are targeting the pituitary gland in something we call medical castration. We target the testicles with surgical castration, and that's what the urologists do with removal of the testes. And our drugs serve the function of a medical adrenalectomy, cutting off the synthesis of other sex hormones. And lastly, we block the hormone or testosterone. It's like older drugs like glutamide, but we have newer drugs like enzalutamide, apalutamide, and darolutamide that block at the site of the prostate. With androgen deprivation therapy, as most of you gentlemen are already aware, testosterone plays a very important function in terms of physiology. And so when you stop a hormone like testosterone, you will have side effects, hot flashes, decreased libido, erectile dysfunction, muscle loss, anemia, osteoporosis, metabolic syndrome, which is essentially a diabetes-like picture where you have a lot of fatty tissue around the abdomen. You can have high cholesterol. This drug does increase your risk for cardiovascular complications, since testosterone is cardioprotective. And a lot of our patients do complain of difficulty focusing because of the cognitive side effects of taking out the testosterone. Other pathways to stop the testosterone or the androgen from going into the cell is the androgen receptor signaling pathway that is in prostate cancer. So this is the prostate cancer cell. We're inside the cell. The androgen testosterone comes into the cell, binds to the androgen receptor that causes dimerization of this. This goes into the DNA. And this causes transcription, which causes the cancer to grow, to survive, and to secrete PSA. Other androgen axis inhibitors is abiraterone, and abiraterone stops the synthesis of mineralocorticoids and glucocorticoids by inhibiting the CYP17 pathway. And so in this fashion, you're unable to make that testosterone. And then we got the androgen receptor agonist, who work down here on the prostate cancer cell, like we discussed, to prevent the cancer cell from getting the androgen or the testosterone into the cell. And so here's just a slide of reviewing these different agents. You got abiraterone. It needs to be taken with steroids because of that ability to block the corticosteroids. And so you need to replace it with prednisone. All these are going to have the universal side effect of a fatigue, edema, and hyper. But each one of these individual drugs, like enzalutamide and apalutamide, they do have a increased risk in falls. Also explains, the small risk of seizures, which is about a 0.9% risk. Darolutamide does not go into the CNS, so you don't have an increased risk of seizures and falls. Here's a slide giving the timeline of these drugs that have been approved. So in 1996, mitoxantrone was the only option patients had, unfortunately, in terms of treatment. In 2004, we got doxataline, the immune-based therapy in 2010. And then, you had the introduction of abiraterone, enzalutamide for castrate-resistant prostate cancer. And over time, we've had new drugs like radium, a radioisotope. You've had expanded indications for enzalutamide, apalutamide, and abiraterone. And here in the advent of darolutamide here in 2019. And then you had the BRCA inhibitors, Operib and rucaparib for homologous recombinant deficient cancers. And so these are going to be our options in the hormone sensitive that is not it's going to be low. Dr. McBride will what is the best approach, prostatectomy versus radiation, plus or minus androgen deprivation therapy. So as Dr. Davis talked about, the higher risk category, the more likely you're going to need hormones, and the duration of hormones can range from 6 months for intermediate unfavorable to 2 to 3 years for very high risk disease. If it metastasizes and you're still castrate sensitive, here are the different options that we've discussed for high volume disease. Here is your treatment options for castrate resistant disease or hormone refractory disease. We always continue the androgen deprivation therapy, even though it's independent. And here are the options for disease that is rising PSA only with enzalutamide, apalutamide, darolutamide, or even observation. For asymptomatic disease, we have the ability to use these particular agents here for for bony only with no visceral disease is going to be in, as well as the abiatronic oral option. Personal trials is always advisable in any disease state. I'm the head of the cancer trials for the prostate group, and we have trials that are early stage trials for early stage disease, localized disease, to options for patients who want to expand their menu of treatment options in the middle of treatment. And then we have options for patients who have exhausted all standard of care options and are looking to look at those options as well. And lastly, pembrolizumab or Keytruda is indicated for MSI high tumors or patients who have a tumor mutational burden of greater than 10. We also, as medical oncologists, want to make sure that we are protecting the bones. So patients who are androgen deprivation therapy, we want to make sure we're getting DEXA scans and screening for osteoporosis. And two drugs is Xgeva and zoledronic acid, or an oral option. And of course, if you have metastatic disease, it's important to prevent fractures and complications from those fractures. So you got zoledronic acid with the denosumab, which are obviously going to be always given with calcium and vitamin D. So thank you very much. I hope I didn't include a lot of redundant information from the other presenters. Thank you very much.
Thank you, Doctor. If you could unshare your screen there, I'm going to change the view for our viewers here so that we can see everybody. We're going to open this up to some questions. I do have a start-off question here, and then we'll get into some that have come in already. Obviously, what's on everybody's minds in these days is the pandemic and COVID-19. Have you noticed in your practices any kind of change in how people how men are being diagnosed and the number of men that are coming to you? I know that here at the Prostate Cancer Support Association, our phone calls have dropped off significantly. But if somebody could just talk to how your practice may have changed and how your treatments might have changed.
I can speak to that, and I'm sure the other panelists can too, but I really haven't noticed a huge change in the referrals for elevated PSA, which is mostly the referrals we get in urology. And that leads to a discussion about prostate biopsy. So I haven't seen a big change in that. I haven't seen a big change in, decisions about treatment. We have had, obviously in the height of COVID, we had delays, and some people who were very anxious about being in a hospital with possible exposure to COVID who wanted to come in for treatment. So some people did delay treatment because of that. And but other than that, I haven't seen a huge difference in either screening or selection of treatment, to be honest with you.
Anybody else?
During the first big COVID restriction that we had for about a year and a half, we did notice, and I don't know if Dr. Avitia noted that as well, that patients came in with more advanced cancers overall. And this was confirmed by ASCO and ASTRO when we did the whole survey of entire field. The patients tended to delay seeking care and resulted in coming in with more advanced and later stages overall. But I think that since it has improved somewhat, seems to have settled down now, and we're kind of catching up.
Good, good. Okay, I'm going to jump to some of the questions that have come in. This was directed at Dr. Davis, but I think it might apply as well to the rest of you. After HIFU or cryotherapy, if PSA remains high, can surgery or radiation therapy be performed to treat prostate cancer?
So obviously I do a full spectrum of urologic oncologic surgery, and that includes bladder cancer. And the answer to that question is yes, surgery can be performed. It's salvage surgery, so basically there's a higher risk to patients. Those risks include bleeding, infection, risk of colostomy, which is not something I think anybody would really prefer after a prostatectomy, and obviously risk of scar tissue formation after surgery. That being said, it can be done, and I do, patients who've had bladder cancer after radiation for prostate cancer, and that's kind of the equivalent thing. It's still a form of ablative therapy, and so the answer to that question is yes, but you have to have a discussion about the risks and benefits going forward. There are other therapies, post-radiation, one can have cryotherapy. And I've even seen patients after cryotherapy who've undergone localized external beam radiation therapy for salvage. So HIFU is, once again, it's indicated for ablation. It's not indicated for cancer treatment. So that's something to keep in mind. And there's not a lot of evidence-based data with that. So I'll let the other panelists comment if they want to.
Can you repeat that question one more time?
After HIFU or cryotherapy, if PSA remains high, can surgery or radiation therapy be performed to treat prostate cancer?
And you're talking about in the context of no evidence of spread of disease, right? Just localized.
I'm assuming that's the case.
Yeah, me too.
Yeah, I
Okay.
think things change after there is evidence that it spreads, correct?
Right.
Yeah. So I would think that, yes, either can be, as long as, like Dr. Davis said, we know that it hasn't spread beyond the prostate, and the patient has had long enough time to recover from whatever procedure they've had done. But I can't point to any studies or trials for that, because that's not a very common situation.
All right. Obviously, screening is a big question that, for everybody. Here, I'll read this question. There appears to be differences between medical groups on PSA screening. The NCCN, and we've already talked about this a little bit, suggests about 40 to 50, and American Urological is very different. But why the confusion? Why the differences? and then he put a postscript here is, are there other kinds of screening techniques that can be looked at here? That includes a blood test versus biopsy.
So really in terms of screening, I think the AUA, most of the cancer consortiums recommend that if you're high risk, certainly you can have screening prior to the age of 55. So that includes African-American race, a family history of prostate cancer. So I think, if you're average risk means you're not African-American and you don't have a family history of prostate cancer, then the recommendation based on the two large clinical trials of screening, which is ER, SPC, and PLCO, if I have that right, or PCLO, is between the ages of 55 and 69. But once again, this is not set in stone. If a man has average risk and they want to start screening at 50, that's a conversation to have with your clinician. So the guidelines are guidelines. They're not laws. So you can be screened, I'm sure, if you want to have that discussion with your physician at pretty much any reasonable age.
All right, thank you. Anybody else? Okay. Since there are so many treatments and so many gray areas, how do you know and feel comfortable that you have a high disciplinary team? This is in quotes. Do all three major health centers in Albuquerque have the same resources and ability to treat prostate cancer?
I would say absolutely, but that's my opinion.
Well, I think, just to answer this patient's question, I always tell patients, having many minds on a problem is better than having one mind on a problem. And so when you have a radiation oncologist and you have a urologist on the problem, like we do in our group and at UNM at Lovelace, you're more likely to get the right answer for the individual patient. And so it's including the multi-specialty approach in treating our patients. And, I think, when you have one sole decision maker, then, there can be, probably not the best of outcomes for patients. So you need to have multiple, brains working on the same problem.
Yeah. So, yeah, I agree with that. And I agree with Dr. Davis. I think that all of us, I think there are several excellent systems that will all do a very good job. The part of the reason I think that there is so much, as the questioner called, gray area, is I'm going to throw it back on you guys. It has been exceedingly difficult to be able to do a reliable randomized controlled trials comparing treatment A to treatment B to treatment C for a most early stage or intermediate risk stage prostate cancer, like we've been able to do for women with breast cancer. So if you were to be asked to enroll in a randomized controlled trial comparing, for example, prostatectomy versus brachytherapy versus external beam radiation therapy, a modality of ABC, or brachytherapy or active surveillance, or even just two of those, and you don't get to choose, and a computer flips and you have to go with whichever because we are not sure which treatment is better, would you sign up to enroll in this study like that? Those kind of studies we've been trying for decades. We've never been able to get it done in a prospective manner, the way it should be done, like we did for women with breast cancer between lumpectomy and mastectomy. So that's part of the reason there are so many gray areas, I think.
All right.
Echo that. I think, once again, we do the best we can with the data we have.
Exactly. Yeah.
And the consensus opinion, a multidisciplinary, evidence-based approach. And so, it's all, as somebody once said, in God we trust, but, the proof is in the data. So you have to look at the data and come up with the best evidence-based approach that you can. And so unfortunately, those trials haven't been done, or they're difficult to do. We still have good evidence-based data that we can use in selecting treatment options for patients.
True.
Okay. Here's a question. After radiation and hormone treatment is complete, is the PSA test the best method to determine the effectiveness of the treatment? Is the PSA test the best method to determine if prostate cancer has returned? And should the patient have screening after treatment is completed?
So
I would
yes.
say, yeah, I'm sorry.
Oh, so I'll just say my piece. So yes, absolutely. After treatment with radiation and hormones has ceased, so routine scans and bone scans to ensure that there's no recurrence. Because as Dr. McBride said in her presentation, this treatment is not in all cases curative, and so you need to be able to catch early stage metastatic disease by screening PSA and CT scans and bone scans. But as Dr. McBride alluded to, there are some cancers that don't produce the PSA antigen, and so that's why you want to incorporate the imaging to catch those cancers that are not producing that antigen.
Yeah, I agree with Dr. Avitia. I think that if patient is in reasonable health in general, just as a rule, following any kind of therapy for prostate cancer, that patient should be followed for foreseeable future, for 10, 15 years, with PSAs and exams and imaging as needed.
And I'll echo on to that. So, there are certain criteria for each treatment modality in terms of what constitutes recurrent disease and so for surgery, it's a PSA of 0.2 and rising. 0.2, you have to have 2 tests over 0.2. For radiation, it's a nadir +2, meaning the lowest level of PSA +2. And then cryotherapy is somewhat of a grayer area. But, hormone therapy or androgen deprivation therapy does kind of muddy the waters in terms of its PSA effect. And therefore, for a patient who's had localized treatment, say for a high-risk cancer with, say, radiation and hormone therapy, if you're continuing on the hormone therapy, PSA may not be a true test of disease recurrence. What we have to remember is PSA is not 100%, it's a surrogate. And it is, basically the best we have, and still the best we have in 2021. So getting to the other thing, most prostate cancers are adenocarcinoma, therefore they produce PSA. When you get into some lower percentages of different types of cancers like neuroendocrine and things of that nature, those are non-PSA producing tumors, but they're not adenocarcinomas either. So we need to keep that in mind.
Thank you. This is, yeah, go ahead.
Oh, just one point I just wanted to point out. If a patient has had hormone therapy along with radiation, and you're being followed, and I just want to make sure that the patients don't get alarmed when they see PSA that went down to 0.01 or something, and it starts to go back up a little bit when the effect of the hormone wears off. And that is normal, and that does not mean cancer is back. So following definitive radiation therapy, the target we'd like to see for PSA is around 0.5, somewhere under 1. So after hormone therapy with with radiation therapy, PSA will get close to 0. And when it starts to go back up, patients get really worried, and just want to reassure you that that does not mean cancer is coming back. You're just getting effects of the hormone out of your system.
And also, Dr. McBride can comment on this, but there's a phenomenon called PSA bounce after radiation
Exactly. Yeah.
that can occur up to 36 months. And so you can see the PSA go up and down. And, you know, that can obviously create some anxiety. So it's another thing to keep in mind.
And people have actually tried to see if having a PSA bounce means anything. And it seems that when there is a little bit of bounce like that, those patients actually do better. So it's not a bad thing.
Okay. This next question is actually aimed at Dr. Avitia. Can you speak to the combination of hormone medications? This person is currently on bicalutamide and a 6-month dose of Lupron. Combination therapies. Can you speak to that?
Yeah, well, you know, in terms of, you know, these are different ways of blocking androgen. And so when, you know, Lupron is, you know, when you go back to my presentation, you can see that you're blocking the, you know, the pituitary gland. And with the bicalutamide, you're actually blocking the receptor on top of the cancer cell. So we do use different modalities of blocking the androgen. And this is very common, especially as you have progression of disease, and you know things like abiraterone. You know you're blocking you know the CYP17 pathway, which are you know blocking the production of corticosteroids, and there with that modality. So it's very common to do that type of blockade. And the other drugs like enzalutamide and darolutamide and apalutamide also, you know, block the androgen receptor in that capacity as well. So this is something that we utilize more so in more advanced disease. And there are clinical trials. There's one at the Cancer Center now where we are using darolutamide in conjunction with radiation and androgen deprivation therapy for high-risk disease.
There's a follow-on question here. At what point do you move to chemotherapy?
Chemotherapy is indicated for high-volume disease in the metastatic setting. So patients who have multiple bony sites of involvement, nodal involvement, that's typically an option either at first diagnosis of metastatic disease or once they've progressed on some of these novel targeted therapies.
Yeah, one of the advantages of darolutamide, my understanding is it doesn't cross the blood-brain barrier, correct? So it's actually
right. So the risk of and the risk is much improved. And you know, there's also patients who also say that they have you know, they don't have that foggy feeling in their head. So I think that's important for quality of life.
Okay, this is getting a little specific here, but this person says they had metastatic prostate cancer stage 4. Treatment was radiation, Xtandi, Lupron, and bone shots. And he's asking, is this effective?
Yeah, you know, I think it's important to understand that this is not a curative treatment. And so all these treatments are meant to control the cancer, to give quality of life, and to prolong survival. And so at some point, the cancer will develop mutations. And as it develops mutations, and it's harder to control, and then you'll have to change the therapy because the cancer adapts, the cancer is able to mutate and evade that particular mechanism. And so the treatment that this patient's on is very effective, but it's not curative.
All right, thank you. This is another question. I thought there was a recent, and this is from an attendee, thought there was a recent study showing that surgery has been more durable than radiation at 10 to 15 years. Is there any study to that effect, or it may have been he says it may have been retrospective. I don't know what that means necessarily, but Can you both, can you all speak to the 10 to 15 year outcome rate?
I'm not aware of the study, that any prospective randomized trial that showed that. The other thing about cancer when you're comparing treatments is looking at the aggressiveness and staging, which is how advanced the cancer is. And so obviously you need to know what context the study was looking at and how advanced, what types of patients with what types of disease. So, when you're looking at external beam radiation therapy, brachytherapy versus surgery, what we know is the outcomes, if you take all comers, are fairly equivalent. And each treatment modality has its, side effects and complications. And really the treatment is what the individual patient is comfortable with and how invasive they want to be with treatment. So,
yeah. So there was, I think it was Lancet Oncology, maybe, I can't remember, but it seems like there was something, some sort of report like that. And if you ever see any study like that, I think it's difficult to interpret because if you have we can't really do prospective trial. All of that is retrospective trial, which means review of patients that were treated. And one of the biggest, I think, advantage of prostate removal surgery is then we have a very good complete information about the pathology, which is sometimes we don't always have that all complete information on biopsy alone. And so you can have a issue with comparing apples and oranges because there is a little bit of a upgrading of stage. And also for the 10 to 15 years, techniques have changed. Prostate surgery technique has improved significantly. Radiation therapy technique has improved significantly. So and you have the patients that are fit enough to be able to handle prostate surgery, which is not a minor surgery. They tend to be healthier and more fit as opposed to not as fit. So it's hard to compare them head to head unless you have randomized controlled trial. And that's where the confusion and judgment and discussion needs to happen.
Okay. Again, this I believe this will be aimed at Dr. Avitia. This is kind of a step back. If you could kind of tell us the difference between hormone therapy and chemotherapy.
So hormone therapy, is the pathway where we block androgen stimulation to the testes, which that's blocking the production of testosterone or what we call medical castration. Chemotherapy, what that does is that it enters the cell, damages the DNA, and as you damage DNA, you're unable to repair it. And when you can't repair but for chemotherapy, it's not a curative approach. It damages the cell enough to slow it down, but it's not a curative thing. Some cancers, chemotherapy, as it enters the DNA cell, it can be curative, like lymphomas, where the disease doesn't come back. But with prostate cancer, the chemotherapy is designed to slow it down. And so those are the two main differences. One is working on blocking the testosterone to getting to the prostate cell, and then the chemotherapy works by damaging the DNA within the cell.
Okay, thank you very much. Here's a question about intermittent hormone therapy and what PSA threshold should be considered for seeking additional treatment.
PSA in intermittent therapy is an arbitrary decision. So it basically is whatever the patient and the clinician decide should be a reasonable PSA level to reinitiate treatment. There's really no data on that.
Okay. All right. Let me look at my questions here again. I had a question too. I think you've already addressed it to some extent. Can you speak a little bit more on the issue of age and prostate cancer? Early or younger people that getting diagnosed with prostate cancer seem to have a little bit more aggressive forms versus older people. Is that true?
No,
No.
not necessarily true.
Yeah, I agree.
You know, I think when in terms of in the metastatic setting, this is probably just clinical experience. You know, anytime I get a 45-year-old who's diagnosed with prostate cancer that's advanced, you know, that clinical course is probably going to be, you know, much faster. There's something about that particular patient group that seems to progress very rapidly, and they quickly run out of options, as opposed to, you know, maybe some of the older folks that present, you know, they tend to have, you know, a disease that is not as widespread and not as hard to control. I mean, again, this is just my clinical experience, but I have seen that, you know, either these guys have a, you know, familial history of prostate cancer, or some genetic driver that is, you know, leading for the diagnosis at an early age.
You know, the older a man gets, the higher the probability they will be diagnosed with prostate cancer. And that's just a fact of an aging male. And that's been borne out in studies done long ago on autopsy studies on men who had their prostates removed. These were men in their 80s. And I think 40% of them had an indolent prostate cancer that never affected their life. So, you know, the question is not, you know, do you have prostate cancer? It is, do you have a cancer that will influence your life expectancy? And so you can have a high-risk prostate cancer as an older man or a younger man. But those are the cancers that we really know will affect life expectancy and quality of life, and the ones that should be treated.
Okay, thank you. Here's another question that just came in. Is there any evidence that any of the radiation approaches or androgen therapies actually facilitate or increase mutation in the prostate and thus are anti-productive?
None that I know of.
Okay.
There is a risk with radiation therapy, though, a small risk of secondary malignancy, you know, many decades after radiation exposure. So that's, but it's a very small, I think it's 2 to 3%. So something to be aware of.
That does kind of tie into another question that came in. It says that patients that have received radiation, is there any data on the risk of other cancers as a result?
So there has been some older studies that reported slight increase in risk of cancers following radiation therapy to prostate, for example, the rectal cancer nearby or the bladder cancer occurring many years, more than 10, 15, 20 years later. The second malignancy is an issue that we tend to worry more about in very young teenagers and people in their 20s as maybe a factor, but not so much in prostate cancer. The risk is low enough.
And those studies were done, you know, they studied, a lot of that was done with men with testicular cancer and retroperitoneal radiation for testicular cancer. And that's where a lot of that data came from. So,
right. And they tend to be very young.
yeah.
Yeah.
Okay. I think we've probably talked about this before, but just one more, if somebody could just respond to this. For someone over 70 with no family history of cancer, and I'm assuming prostate cancer, and in good health, is a PSA test even advised?
If you look at the screening guidelines, you know, that's once again, the guidelines say it's not recommended, but does that mean that the guidelines have to be followed? No, if somebody's in excellent health and wants to be screened, they can be screened. But if you're at average risk, will finding a significant prostate cancer over the age of 70 will statistically affect your life expectancy? Probably not, but screening can be obtained at any age. It's just a shared decision between you and the clinician.
Thank you.
Yeah, I agree. And I think it depends on how thoroughly the primary care physician for that patient does a routine checkup. It just seems like that these days, for whatever reason, many primary care physicians have stopped doing rectal exams, which misses rectal cancers and prostate cancers. So if you have a more thorough approach for your primary care health maintenance, that might be one thing. And it's always sad. I'm sure Dr. Avitia has seen him, and Dr. Davis, is that we'll sometimes see patients who've never had a screening and they show up with PSA and they're thousands and with widespread disease, which is always a tragedy.
And the other issue is, a lot of men don't even know they're getting a PSA test with a slew of blood work. It's not discussed with them. It's just put on a panel and they get the blood drawn. And then, lo and behold, they may have an elevated or abnormal PSA and they get referred to a urologist. And so once again, it's something that if your PCP or is doing, they should discuss it with you before they just knee-jerk a lab test to be included in an annual physical. So.
Yeah, exactly. And, I'm sure Dr. Davis sees a lot of medical students, and we do too. And many of them are going to go into primary practice. And at least personally, I try to teach them how to do a digital rectal exam properly in patients who either have prostate cancer or are being followed with it. Because the doctor needs to know what a normal prostate feels like, what a benign enlarged prostate feels like, and what a prostate with cancer feels like. And you can have a PSA that's over 4 and over 10 with just complete benign gland, like Dr. Davis can tell you.
Yeah, digital rectal exam is very subjective and it depends on experience. So
It's true.
It's one of those things that, especially for prostate exams, at least, it's, I was brought up in the era where screening consisted of rectal exam and PSA. The guidelines now say rectal examination is probably not the best screening tool, but as a urologist, we still include it in our screening for prostate cancer. Anyway, but I think a lot of primary care goes with the guidelines, and they just forego the rectal altogether and just send the blood tests. So.
There have been some things running around on the internet, and everybody knows that the internet is somewhat suspicious. But what about some of the things that are coming out, like liquid biopsies and urine tests for detecting prostate cancer? Are you familiar with any of these new?
There's no evidence-based data that either of those is ready for prime time, and it's probably going to be a while before they are. I mean, the genetic testing is getting better, with the panels of genes that they're looking at, but unfortunately, we just don't have the technology at this point in time to forego a prostate biopsy for diagnosis, which I think we'd all be happy if we could do that. But unfortunately, we just can't at this time. But I think given maybe 1 to 2 decades with molecular biology techniques and some of the other technology, it will be something that we'll see.
Last question here. It's a little specific, but it might be lead into some discussion. I mean, I think we may have even answered this question. This person has a Gleason score of 7, completed 39 radiation treatments, and had put on Eligard for 24 months. And his question is 24 months really required?
He had Gleason what? 3 + 4?
It doesn't say, it just says Gleason 7. So, and that would be a
And his
clarification.
diagnosis PSA was what?
It doesn't say either.
Okay, because it'll depend, you know, risk stratification depends on all of that. And so if he was high risk, yeah, absolutely, that's the right way to go. If he was intermediate risk, then I'll let Dr. McBride comment on that, but
Yeah, so if the patient had a Gleason 3 + 4 for 7 and PSA that's less than 10, probably don't need the hormone therapy. If it's, and I'm sure Dr. Avitia can enter in as well or comment, but if a patient has a higher risk intermediate cancer like 4 + 3 with a PSA over between 10 and 20, adding androgen therapy is absolutely the thing to do. As far as the duration, it's been tested anywhere from 6 months on to 24 months, depending on whose study you look at. So if it's a straightforward intermediate risk, I think the current sort of average is about 6 months. If you are at higher risk of disease, then anywhere from 18 months to 36 months has been tested. And it seems that there is some evidence for improved outcome with longer endocrine therapy. But you have to balance that versus your overall risk and side effects and how you're tolerating the side effects.
yeah, with high risk prostate cancer, the androgen therapy, I mean, that was based on a trial called the BOLA trial. And they basically showed that 24 to 36 months in high risk patients of androgen deprivation therapy plus radiation had better survival outcomes than radiation alone. And
Right.
that's basically standard of care for high risk prostate cancer. Obviously, patients can refuse the androgen therapy, but it's just based on that trial data.
Yeah, I think, yeah, for sure, 6 months based on what the patient is describing, but to echo Dr. Davis's point, it all depends on his presenting PSA and what was the predominant histology on his Gleason to determine whether he needs more, than 6 months. So that's something that he should ask his, treating physician to kind of go over those things. But definitely, you do see, less recurrences, more survival with high risk groups with androgen deprivation going to 24 to 36 months.
Yeah, I just have one clarification question for Dr. Davis. Apparently there was an audio glitch or something that said, did Dr. Davis say HIFU is not recommended as a prostate cancer treatment?
It is not. HIFU is FDA indicated for destruction of tissue, not for cancer treatment.
Okay, thank you.